Spine conditions affect millions around the world, leading to pain, disability, and reduced quality of life. Advancements like robotics and AI, and of course, minimally invasive techniques are revolutionizing treatment.
Commonly, what these patients tell me is they have back pain. They're not able to stand up straight. Some patients have osteoporosis also for genetic reasons, and the first step is to take a calcium supplement with vitamin D and get some sunlight. The majority of patients who are in motor vehicle accidents have a whiplash and have a muscular strain. There are tumors that originate in the spine. They come either from the bone of the spine or from the nerves in the spine or the spinal cord or the lining of the nerves. If the tumor is located in the front of the spine, sometimes we go through the front, through the chest, or through the belly. If you have a problem like a scoliosis, a kyphosis, low back problems, you have a tumor in your spine, don't think that it can't be treated. Surgery has very good outcomes now. Just finding a good surgeon and having them take care of you.
In each episode, we dwell into the realms of wellness, exploring the latest trends, expert advice, and practical tips to help lead you a happy, healthier life. We aim to bring a broader perspective to our American audience on issues that impact your daily life by interviewing guests from the US and around the world. From nutrition and fitness to mental well-being and beyond, we're here to empower you with knowledge and inspiration. So whether you're looking to boost your energy, revamp your diet, or simply trying to find a balance in your lifestyle, you're at the right place. Join us as we embark on a journey towards a better, brighter you. I'm your host, Dr. Amir Khan, and together let's unlock the secrets to living life to its fullest. How are the latest advancements in neurosurgery transforming lives, from minimally invasive techniques to enhanced recovery methods? Today, we're delving into the world of neurosurgery, specifically spine health and its interventions. Spine conditions affect millions around the world, leading to pain, disability, and reduced quality of life. However, advancements like robotics and AI, and of course, minimally invasive techniques are revolutionizing treatment, offering patients safer procedures, quicker recoveries, and a renewed chance at a pain-free life. Welcome to another episode of Khan Klinics, powered by the health sections of AMT. I'm your host, Dr. Amir Khan. Our guest today is Dr. Praveen Mummaneni. Dr. Praveen is the Joanne O'Reilly Distinguished Professor in Spine Surgery at UCSF. He's a neurosurgeon who serves as the co-director of the UCSF Spine Center and is also the Vice Chancellor of the Neurosurgery Department. He is a lead surgeon of the UCSF Perioperative Services team. He specializes in minimally invasive surgery, complex surgery, and cervical spine disorders. His commitment to advancing both clinical practice and surgical education has earned him a wide recognition. He's the past president of the California Association of Neurological Surgeons and the San Francisco Neurological Society, and currently holds the director role of American Board of Neurological Surgeons. He's been featured in the U.S. News and World Report Best Doctors in America and Super Doctors by San Francisco. Moreover, he has over 530 peer-reviewed articles and has edited 20 textbooks. He's also earned a Master's of Business Administration degree at Louisiana State University. Dr. Praveen, privileged to have you. Welcome to the show.
Thank you, Dr. Amir. It's a pleasure to be here with you and your audience.
Let's dive right into it. We're going to be talking about spine deformities. Want to hear your view about what are the common spine deformities you encounter in clinical practice.
Sure. My practice is based on adults, and the spine deformities I see in adults are typically lumbar scoliosis. There can also be cervical kyphosis or disorders of the neck, and there can also be lumbar flat back kyphosis, which is again the low back. Those are the three most common that I see in the adult population.
Would you mind telling us a little bit about the scoliosis and the cervical spine issues that you encounter?
Sure. So what happens is that some patients can have a scoliosis when they're a teenager, and then as they age into their 60s and 70s, the discs degenerate because the spine is not stably balanced. And so their scoliosis can worsen as they age. So that's one kind of scoliosis, which is an adolescent or teenager type of scoliosis that gets worse when they get older. Another kind of scoliosis that patients get is adult degenerative scoliosis, which means that when they were teenagers, they did not have any curvature of the spine. But what happened was, as they became adults, the spine asymmetrically eroded the disc spaces, and then they started tipping into a scoliosis. And also they could lose the curvature of their back and not be able to stand up straight, and that's called as kyphosis. So those are the two most common in the low back. In the neck, what we see most commonly is also kyphosis, which means that instead of holding your neck up straight, the chin starts to go downwards towards the chest and sometimes can get stuck onto the chest and they can't hold their head up. There's multiple different causes of that as well. But those are the three most common issues that I see in the adults.
Thank you for explaining that, Dr. Praveen. That's a good insight. Tell us, Dr. Praveen, what would be the first symptoms that these patients would present to your clinic? What do you see commonly that alerts you, this may be a spine problem and it could be at the back or the cervix?
So I think we'll start with the low back first, since that's the most common. What I typically see is the patients can't seem to stand up straight, and they're either leaning to the side or they're leaning forward when they're walking, and they have to bend their knees and they have to bend their hips to try to compensate so they can look straight ahead when they're walking. Otherwise, if their hips or knees were locked straight, they'd be looking down towards the floor because they have lost the ability to stand up straight. Also, when you look at them from the front, they may be leaning one side or the other, and that's again because the spine has gotten crooked and they're leaning off to one side or the other. Commonly, what these patients tell me is they have back pain. They're not able to stand up straight. They can only walk for very short distances for maybe a minute or two, and then they feel like they have to sit down because they just don't have balance in their posture. And in the neck, what they tell me often is that they can't seem to hold up their head, that they're looking down at the floor, and if they really get their chin stuck on their chest, sometimes they have trouble swallowing and trouble, breathing and doing exercise because they just can't seem to get their head up and get the inspiration going. So those are the common symptoms that I see in the low back and in the neck. In the low back as well, patients will tell me that they have back pain as well as leg pain, and that's typically because the nerves are getting squeezed by arthritis.
Thank you for explaining that. A follow-up question would that be, if they're having lower back pain and they start noticing pain in the legs, does that alert you to do something different, or how would you go about investigating that?
Yes, many patients in the United States have low back pain and leg pain. And commonly, this is due to things like herniated disc or to arthritis in the low back. Many of those patients do not need surgery. They typically can get better with some physical therapy, sometimes with injection of steroid or taking steroid by mouth. And those are things that typically the primary care doctors will try first before they send them on to the surgeon. If they should fail these non-invasive therapies, getting an MRI is typically what's done next, and then they end up seeing me to see what else needs to get done. So, but it's very common. Most patients who have back and leg pain will get better without surgery. Some of them have back and leg pain from severe arthritis and from scoliosis, and those are the ones I end up seeing.
Thank you for clarifying that, Dr. Praveen. Dr. Praveen, two types of patients have commented about back pain. One has been elderly patients, and they're reporting osteoporosis. I have that. I know it from my scans. What should I be looking out to prevent spine deformities or pain. And
Yes.
then there is a motor vehicle type, which I will come to you afterwards, asking about how would they be recognized symptom-wise and what do you do in their cases?
Yeah, osteoporosis has multiple causes. It's very common as adults for people to drink very little milk or take very little calcium. And so they just basically, as they age, they leach the calcium out of their bones and their bones become weakened. This especially happens in women who have had menopause, that they really leach the calcium out of their bones very quickly. And, if you don't check with the bone density score, you don't know. Patients who come to my clinic, whether they're male or female, and they are having back problems and I'm considering surgery, I will typically send them for a bone density test now because I want to know how much osteoporosis they have. What surprises me is almost half of them have osteoporosis. Wow. Or they have osteopenia, which is sort of halfway towards osteoporosis. So that is an issue sometimes related to diet. Some patients have osteoporosis also for genetic reasons, and it runs in their family. That they just do not have strong bone, and as they age, the bone gets weaker and weaker. But I think a lot of it is related to the way in the United States that we have a diet that does not really have a lot of calcium in it as we get into our 50s, 60s, 70s.
Thank you for explaining that. Dr. Praveen, so would you be recommending our patients, or especially those who are elderly, to try to get some calcium, get some vitamin D, get some sunshine, and definitely opt to supplement their diet if they have
Yes, I think that this can be guided by the primary care physician by getting a bone density study. And if the bone density is off, then the first step is to take a calcium supplement with vitamin D and get some sunlight. If the bone density is really poor, then sometimes medications are necessary.
Thank you for explaining that. I'm just going to send that message out to everyone. Motor vehicle accidents. Patients sometimes don't notice back pain, and then they don't notice any cervical spine issues. But all of a sudden, a day or two, they start noticing some neck pain or even numbness in the hands. What's your guidelines to advise these patients about, hey, when should you follow up? Should you always report to your primary care? How do you go about to tackle these patients?
Yeah, the majority of patients who are in motor vehicle accidents have a whiplash and have a muscular strain. That's the majority of them. Whiplash and muscular strain will cause neck pain, may cause some low back pain. Usually those pains do not radiate into the arms or down the legs. Usually there is no weakness. And often that kind of whiplash type of pain will get better with things like hot packs, some anti-inflammatory medicines like Motrin, and typically will get better with time. And those that don't get better, typically then the primary care doctors will see them and may get some x-rays to make sure that there's nothing inside which is broken. When I get concerned is if patients have not only the neck pain or the low back pain, but they also have nerve symptoms. They start having pain that runs down their arm, pain that goes into their hand, difficulty picking up objects, or their handwriting gets very poor, or in their leg, they're having pain running down the leg, or in some situations, the leg is weak. Those patients, I think we should get an MRI and take a closer look.
Excellent. Excellent. Okay, so watch for the symptoms and keep monitoring them. And if there are concerns, reach out to your primary care. And obviously, there's some certain tests that you need to do. An MRI is one of them that's strongly recommended to make sure that this is not something that need treatment further. Thank you for explaining that. Dr. Praveen, we're going to go to the next topic, and that is about spinal tumors. You have extensive expertise on that. And on this topic, can you give us an overview, first of all, of when would someone be concerned about, hey, I may have a tumor in the back? That's question number one. And then the question number two would be, how would they go about investigating it?
So I think to answer your first question, there are two types of tumors that typically I see. There are tumors that originate in the spine. They come either from the bone of the spine or from the nerves in the spine or the spinal cord or the lining of the nerves. Mm-hmm. Those are called primary spine tumors. Mm-hmm. And then there's another kind of tumor where you have cancer somewhere else and the cancer spreads around the body, and one of the areas it spreads is to the spine. And that is called as metastatic tumor. So those are the
Sure.
two most common types of tumors that I see in the spine.
Sure.
When do patients typically end up seeing me? They usually see me because if they have had back pain, again with either arm or leg pain, with or without weakness, and the primary doctor or their neurologist or another surgeon has ended up ordering an MRI, and then a tumor is found on some part of the spine.
Sure.
And that's usually typically when they end up seeing me. Rarely I have somebody coming to the emergency room because they can't walk, and we do a scan and we figure out that they have a tumor, and that's the reason they can't walk, or they can't control their urine with weakness of their legs, and it ends up being a tumor causing that.
Thank you for explaining that, Dr. Praveen. Dr. Praveen, give us a little follow-up as to when you see a patient and you say, oh, this one has got probably cancer on the spine. How do you go about, what's the term say, staging them? Which ones do you operate and which ones you don't?
Yes, I think that's a very important question, Dr. Amir. So essentially what happens is at our institution here at UCSF, we have a team approach to cancer patients. So the team includes an oncologist, which is a medical doctor who evaluates cancer.
Yep.
It may include a radiation oncologist, who is a doctor who does radiation for the spine. It includes typically a surgeon, which in many cases is me, but I have several colleagues who also will see these patients. And so the three of us will typically communicate together.
Sure.
And so the oncologist will do what's called a cancer staging if there is cancer that is elsewhere and spreading to the spine. So they will do a stage with a full body PET CT scan, which looks from the head to the toe and says you have tumor in this number of locations. Once that is done, then the oncologist can give us an expectancy of lifespan. And
Sure.
if they say this is, somebody who is a young person, has widely metastatic tumor, but these kinds of tumors, say it's breast commonly in a young woman, or one of the most common ones I see in men is prostate cancer. These are very treatable cancers. So then they will say, based on the tumor burden, we have this kind of chemotherapy, this kind of radiation therapy. They have a lengthy lifespan. You should think about doing tumor surgery for the spine. And that's usually the type of team approach that we take here, where we evaluate the patient head to toe, and then we make a decision based on how aggressive to be to go after the tumor in the spine, based on what kind of tumor are we treating, what is their deficit, and can they not walk, or what's weak, and what is their lifespan.
Thank you. That's a very thorough answer, Dr. Praveen. Thank you for explaining that. Dr. Praveen, just on the same topic of spinal tumors, tell us a little bit about what are the surgical approaches that you have or there are to treat someone who may have a cancer on his bone, and especially spine, obviously, in this case.
Yes. So there are a variety of approaches to treat tumors of the spine.
Sure.
If the tumor is located in the front of the spine, sometimes we go through the front, through the chest, or through the belly, or through the front of the neck. If the tumor is located on the back of the spine, we will approach typically from the back with an incision in the middle of the back, or the back of the neck, or wherever it is, coming from posterior. Rarely we have to do both anterior and posterior, meaning we go through the belly and the back, combination approaches. Depending on the size of the tumors and their location, many of them can be treated now minimally invasively. And minimally invasively means that we put the tube right on top of the tumor if it's small, and through this very small 2-centimeter tube, we then remove the tumor through that. Some patients, the bone is destroyed, and so we have to then put in screws and rods to stabilize the spine, plus take out the tumor.
Sure.
In those also, our institution and several others have pioneered minimally invasive approaches where we can put the screws in with several small incisions, open up just where the tumor is and put a tube there, take out the tumor, and then slide rods in with minimally invasive techniques without having a big open incision. When we do those kinds of maneuvers, we basically will lose less blood because we're creating less trauma to the muscles and the tissues. And many times we don't have to go to intensive care or give a blood transfusion, depending on what kind of tumor that we're treating. And those are the latest things that we're doing for the tumors. Occasionally, we will give radiation to shrink the tumor and then do surgery. In other cases, we will do surgery and then do radiation afterwards. Depends on what kind of tumor we're treating.
Wow. Thank you very much for explaining that, Dr. Praveen. That's excellent. One of the buzzwords that's out there right now, and a lot of people are asking, is about robotics and AI. Is that playing any role in spine surgery? Is it helping?
Yes, so I think that spine surgery is evolving. And if I just look back, I trained in the 1990s. And if I look at how we did spine surgery then versus how we do it in 2024, it's vastly
Mhm.
different. Minimally invasive
Okay.
surgery was not really being done in the 1990s. Many of these new
Mhm.
techniques were not available. And I think in the next 10, 15 years, you're going to see a lot more robotics and the use of AI in surgery. And it's coming because the robotics equipment is getting more and more sophisticated. It's
Right.
lining up directions for us to put the screws. It's lining up approaches now in the future, probably to help us to do laminectomies as well. So I think you're going to see a lot more use of robotics in the coming decades. Today, right now, we have a robot at UCSF. We use it for some cases. It's not really adding extra to what we can do without the robot.
Mhm.
But I think in the future, this is going to change. The other thing which is happening is robots are being married with navigation. So navigation has already revolutionized spine surgery over the last 10 to 20 years. In navigation, we take a pointer and we can point at certain areas of the spine. We can put trajectories for our screws with computer navigation. We can open smaller incisions and we can look inside based on, looking through a tube with the navigation system. That's being married to robotics. When that marriage happens and becomes very sophisticated with a couple of generations of robotics down the line, I think this is really going to make surgery much more sophisticated and much more accurate. As for
Excellent.
AI, AI is currently being used in the research realm to look at
Mhm.
large data sets, to look at pattern recognition, patterns that we don't recognize as humans, and to see if we have a pattern recognition which can help us to guide treatments. So I'll give you an example of this. I'm a member of the Quality Outcomes Database SpineCore group. This group is with 13 different sites merging our data together and then doing pattern recognition for things like spondylolisthesis, which is slippage of the spine. So when we do that, we are finding some trends which we find to be very interesting on how patients recover from surgery, predicting who's going to have a problem, looking at much larger numbers than just an individual practice like mine. In addition to that, I also am part of the International Spine Study Group for scoliosis, and we're looking at minimally invasive cases there in large numbers among several centers. And again, looking for pattern recognition of who does well after scoliosis surgery, who's going to have a complication, trying to do the prediction of those issues, and then trying to see if we can mitigate before a problem happens. So I think on the research realm, AI is going to be really efficient. Will AI make its way into the operating room? I think it will, but it's not there right now. And I think in the next 10, 20 years, it'll be interesting to see how it marries with robotics.
Excellent. Excellent. You're still optimist. That's good, right?
Yes, I
That's
think
good.
we're going to do surgery in a much safer way, a more accurate way, and even more minimally invasive in the future than what we're doing now with these new technologies.
Well, thank you for giving that hope and giving that recognition. Dr. Praveen, what do you anticipate as being the next big breakthroughs in the neurosurgical field specifically? And if we talk about just general spine health, what's on the horizon? Tell our audience a little bit about that.
Yes, I think there are some interesting research works that are being done on the brain-machine interface and the interface for creating the ability for patients who are paralyzed to do walk with assistance of robotics, with assistance of computer technology. And I think that that's going to be something that'll be very interesting to see over the next coming decades. In addition to that, I think that again, there's going to be AI with robotics and machine learning that happens in the operating room, and perhaps the surgeon will come in, wear a headset. The headset will display all kinds of different information. You'll marry that with a robot, and the robot will help you do the surgery. Some very interesting things are going to come down the pike.
Well, thank you for explaining that. What advice, Dr. Praveen, would you give to patients and the families who are dealing with chronic spinal deformities or even tumor diagnosis? Any advice from a surgical surgeon about the disease or pathology that they have?
Yes. The advice that I would give is, first of all, if you have a problem like a scoliosis, a kyphosis, low back problems, you have a tumor in your spine, don't think that it can't be treated. There's a lot of fear around these diagnoses, especially when someone uses the word tumor. All kinds of things come into people's minds. And what I can tell you is many patients, even with very complex deformities or complex tumors, we can treat them today in 2024 in ways that were not imaginable just 5-10 years ago. And I think there's a lot of hope for functional outcome, recovery of their function of walking, using their arms and legs, and pain relief through surgery, which you don't have to be afraid. Surgery has very good outcomes now. And, finding a good surgeon and having them take care of you, you're likely to get better and become functional. So I would say fear is the thing to fear itself. We don't need to really think about fear. Find someone who you can communicate with as your physician and let them take care of you. And I think the outcomes, you'll be surprised, are much better than what historically people have thought about spine.
Well, thank you, Dr. Praveen, very much. And I'm afraid that's all the time we have for today. A huge, huge thank you, Dr. Praveen, for sharing your valuable insight and, of course, your time. We really appreciate it.
Thank you, Dr. Amir.
Thank you for everyone being with us. Thank you for the opportunity. And I want to thank my team who brought this presentation. This presentation was brought by Khan Klinics, powered by American Muslim Today. Please don't forget to subscribe, share, and comment in Khan Klinics. Thank you.